Okay, great. Well, I think everyone is in from the waiting room, so I'm going to get us started. Good afternoon, everyone. Thank you so much for joining us today for AIMED Alliance's Copay Accumulators 101 webinar. My name is Ashira Vantries, and I'm a staff attorney at AIMED Alliance. So for those of you who don't know, AIMED Alliance is a 501c3 not-for-profit health policy organization that seeks to protect and enhance the rights of healthcare consumers and providers. And I'm joined by Charlie Husser from the Alliance for Patient Access and Carl Schmid from the HIV Hepatitis Policy Institute. And I briefly wanted to provide them both an opportunity to introduce themselves. Carl, would you like to start?
Sure. Thank you, Ashira. It's great to be here. Carl Schmid. I'm Executive Director of the HIV and Hepatitis Policy Institute. We're a 501c3 headquartered in Washington, D.C., and we advocate on behalf of people living with and at risk of HIV, people with hepatitis, and work a lot with other patient groups as well, people with chronic conditions who rely on prescription drugs, just like people with HIV and hepatitis do.
Great, thanks so much. Charlie, would you like to introduce yourself?
Thanks, Ashira. My name is Charlie Husser. I'm a state policy manager for the Alliance for Patient Access. The Alliance for Patient Access is a national network of policy-minded healthcare clinicians that are focused on patient-centered care. And like Carl, we work nationally with many other patient advocacy organizations, as well as do a lot of work in the States. Thank you.
Great, thank you so much. So with today's webinar, could we advance the slides, please? With today's webinar, we're aiming to provide a broad overview of Copay accumulator programs and the variations we have seen these programs take over the last couple of years. So Charlie will be providing us with an introduction as to how Copay accumulator programs came about and how the accumulators and Copay Maximizer programs are working. I will then be providing an overview of the non-essential health benefit schemes that we've seen pop up in recent years and issues relating to copay reform and health savings account and the IRS's 2004 notice. And lastly, Carl will be providing us with an explanation of why these programs are harmful for patients and how patients and patient groups can get involved in advocacy surrounding copay accumulator reform. So if we can advance the slides to Charlie. Charlie, I'll hand it over to you.
Perfect. Thanks a lot, Ashira. As Ashira mentioned, my name is Charlie Husser. I'm State Policy Manager at the Alliance for Patient Access. And today I'll start off by doing a little bit of level setting on what exactly are Copay accumulators and Copay Maximizers. Next slide, please. So before we can get into what exactly are Copay accumulators and Copay Maximizers, I'd be remiss if I didn't at least do slight level setting on patient cost sharing and where we are currently. And so to begin, a recent study by NIH has shown that they expect in 2021 for drug spend to increase year over year to about 4 to 6%. And this is very important because we're seeing recently insurance companies have started attempting to shift the cost to patients. And so over the years, we saw the copay model be the predominant model that we saw as far as patient cost sharing goes. There was a flat amount that a patient was going to have to spend per prescription, and they paid it and they got out. Unfortunately, with drug costs rising, insurers are starting to move towards a co-insurance model. And a co-insurance model is a little bit more complicated and is a little bit more expensive. So a co-insurance model requires a patient to pay a percentage of the list price of that medication. And so if we took one drug that was $1,000, and let's say a patient paid a $30 copay for that medication, but if a co-insurance patient had to pay 30% co-insurance, that patient is paying $300 instead of the $30 copay. And so these co-insurance models will shift the cost heavily towards patients. Combine that with the fact that insurance companies are starting to place a lot of drugs on their quote specialty tier. Specialty tier drugs are among the highest cost and are typically used to treat chronic conditions such as cancer, blood disorders, or arthritis, and are often with the higher co-insurance. So the rise in prevalence in co-insurance has led many in the patient community to try and find a way to allow patients to access their medications. And one way that they have started to do this is through manufacturer and third-party assistance. This can either come, like I mentioned, from manufacturers or third-party entities such as nonprofits. Next slide, please. So we mentioned in the first slide prescription drug tiers. And so I'd like to do a quick level setting on what exactly they are. And they are a formulary design tool that is utilized to make the more expensive medications difficult to read for patients. And so how do they do this? Well, they'll take the more expensive medications for them and put them on tiers that are higher. They will also often require them to pay co-insurance for these medications. And because of that, they are often more expensive than a medication that may have a copay attached to it. And so if we take a look at the chart to the left here, this is a Kaiser Family Foundation survey on strictly employer plans. And if we take a look at it, 48% of firms have 4 or more tiers, and another 35% of them have 3 tiers. And so if we do a little bit of quick math, that brings us to 83% of firms that have at least 4 or 3 tiers. And so what does this mean for patient? It means more often than not, there is a specialty tier or a co-insurance tier in their insurance. And that often leads to them paying more for their medications. Next slide, please. And so now, how are insurers responding to these new assistance programs that I mentioned earlier? How are they reacting to manufacturers requiring patients to come and get this assistance in order to be able to afford their medications? Well, they're working on new programs called Copay Accumulator programs. We first saw these surface around 2019, and this is the practice in which insurance companies will accept the assistance that the patients are using to pay for their medications. However, they won't include that assistance in their third-party payments, in their patient deductible as well as their out-of-pocket maximum. And this is unfortunate because according to recent Kaiser Family Foundation information, 1 in 4 health plans are instituting a copay accumulator program at some level. And this is very disheartening because we've seen through data and also through anecdotal evidence that if payments are made towards a patient's out-of-pocket maximum, then the patient will most often continue to access their medication and stay stable with handling their condition. However, if this payment is not included in their out-of-pocket maximum and their deductible, it usually leads to patient abandonment due to the fact that they are then responsible for handling the out-of-pocket commitment that was not handled by their copay assistance. This leads to a very difficult decision for patients. Do they find the money that they need for their medication, whether it be taking out a loan, going to their friends and asking for help or some other manner? Or do they abandon their medication altogether so that they can afford the other life necessities that they're going to need to get? Next slide, please. And so I wanted to take a minute and take a look at this wonderful chart done by the AIDS Institute on state copay accumulator programs in 2022. And for this, I really want to focus on 2 very big metrics here. And the first is the very top, the copay assistance. In both of these programs, the top being one without a copay accumulator program and the bottom being a plan with a copay accumulator program. Both of these programs will accept the copay assistance. However, the major difference is at the bottom, what the consumer will pay throughout the plan year with and without a copay accumulator program. Without a copay accumulator program, the patient is only responsible for $1,350. Once the copay assistance runs out in July, then they're responsible for the remainder of their out-of-pocket maximum for the year, and that comes out to about $1,350. On the bottom, where none of the copay assistance applies to the out-of-pocket maximum for the year, the consumer doesn't even begin paying towards their out-of-pocket maximum until that copay assistance runs out in May. And so because of that, this patient is required to pay $7,900 out of pocket. And so this is just one example to show that copay accumulators do require patients to pay a lot more out of pocket than they would have if there was not a copay accumulator instituted in the first place. Next slide, please. So Copay Maximizers. This is a newer program that we've heard about in recent years. As we've heard at the state level, and as Carl will mention later on in the presentation, states have started to work on copay accumulators, banning them in some states. And so insurers have turned in some states and federally to Copay Maximizer programs. These programs are where the insurer and the patient will enter into a separate agreement, and the insurer will accept the coupon or the assistance on behalf of the patient, but the insurer will find the average of that assistance over the 12-year period and then take that out so that they average it out month to month, and that is what the patient will pay. And so in copay accumulator programs, where there are times where the entirety of the copay assistance may not be utilized, Copay Maximizers, it will always be utilized. They will take however much assistance is available to the patients, find out how they can average that out throughout the 12-month year, and then that will become the copay for the patient. And this is very, very disheartening, both due to the fact that it leaves patients, again, high and dry due to the fact that none of these payments that they make go towards the out-of-pocket maximum or the deductible of the patient. But it is also very, very disheartening due to the fact that this doesn't even reflect the actual price of the medication itself. Insurers are placing an arbitrary price on the medication based on the amount of copay assistance available to the manufacturer. And that also is very dishonest towards the patient as well. And so due to that, patients are hurt in many different ways, but most importantly, it leaves them with a very large financial obligation in being liable for all of their out-of-pocket expenses for the year. Next slide, please. And so what effects do copay maximizers have on the patient community? Well, just like copay accumulator programs, insurances don't include these payments made into the patient's deductible, even though they received 100% of the assistance. And so just like with copay accumulators, it can leave patients on the hook for, $6,000, $7,000, $8,000 a year. And that's just not okay. And so due to this, despite the entirety of the assistance being spent, and the patient still being liable for their out-of-pocket expenses, this is just an issue for patients that cannot continue. Next slide, please. And so I just want to end it on a few patient challenges that we've seen throughout the years with both copay accumulator and copay maximizers. We already know that costs for therapies are increasing. We're also seeing costs of premiums increasing. And so because of that, patients are just left more and more and more in financial need for help in accessing not only the treatments, but also the insurance that they're required to have in order to have any chance of affording these medications. There's also a very, very large kind of worry that this can lead to treatment abandonment. Stat News has a recent statistic that they found that 2 out of 3 Americans will abandon their treatments when their out-of-pocket out-of-pocket costs exceed $250. And many of us know anecdotally that $250 is not much when we get onto a lot of these specialty medications and higher tiered medications. And so that leads to the possibility that there will be health stability at risk. These treatment abandonment issues can lead to higher costs to not only the patient, but also the healthcare system due to increased trips to the emergency room, more doctors' visits, and the requirement for more and more medications in order to attempt to get the condition back under control. And so due to many of these reasons, we have a lot of concerns about copay maximizers and copay accumulators. And that's why many organizations have been working at both the state and the federal level to ensure that these programs can't harm patients anymore. Next slide. And with that, I believe I'll kick it over to you, Ashira.
Great. Thanks so much, Charlie. I think that foundational understanding of how these copay accumulator programs and maximizers are working is really important as we start talking about this non-essential health benefits scheme and this issue with the IRS's 2004 notice. So first, I'm going to address how some plans have been adopting this non-essential health benefit scheme. But before I do, I want to first explain what exactly an essential health benefit is. Next slide, please. So when the Patient Protection and Affordable Care Act was passed, also known as the ACA, it created 10 essential health benefits that plans were required to cover. So the designation as a health benefit, essential health benefit, is important because under the ACA, essential health benefits are subject to annual limits on cost sharing. And so these EHB requirements created in the ACA apply to both individual and small group plans, and they can also apply to employer-based plans and large group plans that are voluntarily providing coverage of an essential health benefit. Next slide, please. So prescription drugs are one of the 10 essential health benefits. Therefore, any plan that offers coverage of a prescription drug must comply with the ACA's limits on cost sharing. However, in an attempt to avoid these limits and exploit copay assistance, health plans have determined that despite being a prescription drug, specialty medications are not an essential health benefit. Essentially, what these programs are doing is they're carving out specialty medications from the definition of a prescription drug as an essential health benefit. So as a result of using this definition, plans place certain specialty medications on their non-essential health benefit list, and then they contract with a third party to run their Copay Maximizer program for those specialty medications. Next slide, please. So for patients, once a plan adopts this non-essential health benefit definition, patients who take a specialty medication that is on this non-EHB list are contacted and told that they can enroll in this specialty program and receive their medications for $0 a month. And if they do, on the back end, this operates like a maximizer program. So just like Charlie was talking about, they're taking the maximum amount of manufacturer assistance, dividing it over the course of 12 months to determine what the monthly amount will be. And so like a maximizer program, this assistance does not count towards meeting the patient's cost sharing requirements. This non-EHB scheme is especially harmful for individuals who choose not to enroll. So if an individual doesn't want to enroll in this program, they're told that they will have to pay between a 30% to a 50% coinsurance to get their medication. And for the individuals who don't want to enroll, this 30% to 50% coinsurance is still not counting towards their deductible or their annual out-of-pocket limit. Next slide, please. So at AIMS Alliance, we think that this non-essential health benefit scheme could be potentially violating the ACA and its implementing regulations in two ways. So the first way that we see this violating the ACA is violating the ACA's cost sharing requirements. So as I mentioned before, under the ACA, all patient contributions to an essential health benefit must be counted towards their cost sharing requirements. And under these programs, when an individual chooses to not enroll in the specialty program and they're paying that 30% to 50% coinsurance, that amount should be counting towards their annual limit and deductible, and it's not. So we think that could be a potential violation of the ACA. Next slide, please. So the second way that we see this violating the ACA is violating the definition of an essential health benefit. So plans are allowed to create their own definition of an essential health benefit, so long as it's consistent with HHS approved guidance and regulations. So far, HHS has created a very narrow exception to the definition of a prescription drug as an essential health benefit. So this narrow exclusion was created in 2014, in which HHS said that you could exclude the amount of cost sharing that a patient was paying if it was for a name brand medication that had a generic alternative. So in that very narrow case, HHS has permitted that cost sharing to be excluded. But what's happening here with these non-EHB programs is much broader than that very narrow definition that HHS has allowed. So with these programs, the list of specialty medications that are on these lists, many of them do not have any generic equivalents. So it's not really appropriate for these plans to rely on that 2014 exception and take a much broader approach than HHS has allowed. So we think that could be a potential second violation of the ACA. Next slide, please. Now turning to another issue, not related to the non-EHB scheme, but another issue that we're seeing with copay assistance and a copay accumulator reform as it relates to high deductible health plans and health savings accounts. In 2004, the IRS issued a notice that said beneficiaries with a high deductible health plan and health savings account could not use the amounts from discount cards to meet their cost sharing requirements and annual deductible. Fast forward 15 years, in 2020, HHS has now said that this 2004 notice from the IRS also applies to copay assistance. Therefore, patients with a high deductible health plan and an HSA cannot use their copay assistance to meet their minimum deductibles. Essentially, this is creating a copay accumulator program. Next slide, please. So applying this notice, this 2004 notice to copay assistance raises some questions when we're talking about the broader conversation about copay accumulator reform and really how this interpretation falls into the development and adoption of state legislation that can protect against these programs. So at AIM Alliance, we believe there's three main reasons that this 2004 notice should not be relied upon, and it should not act as a barrier to copay reform. So specifically, we don't think this should be a barrier because this interpretation that if an individual accepts copay assistance towards meeting their cost sharing requirements, that they would be prohibited from contributing to their HSA account is inconsistent with the HSA statute. Second, the IRS notice itself is not a binding document. And lastly, the IRS notice improperly conflates discount cards and copay assistance when they're different things. Next slide, please. So specifically looking at the inconsistency with the HSA statute. The HSA statute provides requirements for when someone is allowed to have an HSA account. So that requirement is having a high deductible health plan, solely being covered by that high deductible health plan, being under the age of 65, and not being listed as a dependent. The HSA statute does not say anything about copay assistance being used or being a disqualifier to having a health savings account or contributing to it. So this justification that the IRS notice would somehow inhibit copay assistance from counting towards the patient's cost sharing requirements is just not supported in the statute. Next slide, please. Second, the IRS notice is not a legally binding document. So the 2004 notice is a guidance document. And according to the Office of Management and Budget's final bulletin for agency good guidance practices, guidance documents are not legally binding. So federal agencies can conduct their own legal analysis and determine the extent that the IRS notice is correct. But it's not binding on them and it shouldn't be treated as that. Please. Lastly, the IRS's 2004 notice and the interpretation that it should also apply to copay assistance conflates what discount cards are compared to copay assistance. So discount cards have an unlimited amount of discounts that can be used, and they're used at the pharmacy counter for individuals who don't have insurance or as an alternative to insurance. Compared to copay assistance has a limited amount and it can be used in conjunction with insurance. So these really are two different things, and we don't want to have discount cards and copay assistance be conflated into one thing when they're not. Next slide, please. So really, what are the takeaways here? I know it's a lot of information, but what we're encouraging groups to do is to advocate for accountability for these non-EHB schemes. We think it's a really dangerous precedent set to allow these plans to create these overly broad definitions and create exclusions to what really are 10 essential health benefits that provide extremely important protections for patients. And in terms of the IRS and HSA issue, we want to encourage legislators and groups to conduct their own legal analysis on the issue and determine if you align with aimed alliance analysis. And also continue to advocate for the importance of copay assistance being counted towards patients' cost sharing requirements if they have a high deductible health plan, because many times these high deductible health plans with health savings account are the only options a lot of employees are getting from their employers. So they have no other choice but to take this. Next slide, I'm turning over to Carl now to talk about the patient impact of these programs.
Great, thanks, Ashira and Charlie. Great job of explaining all of this situation. And what I'm going to do is talk about how this impacts the patient and also what we're doing to fight back. Next slide. So I'm going to talk about the impact of copay accumulators on patients. And then talk about some of the action that's already been taken to address these issues, some successfully, some in the works, both at the federal and state level. And then I'm going to talk about advocacy efforts that everyone can partake in, both at the federal level and at the state level. Next slide. So, to look at the patient impact, I guess you really have to look at who are the patients that are being impacted and at what level. And, as you heard earlier, a lot of them, the accumulators are based on high cost specialty drugs. And this is data from TrialCard, and they're a group that actually runs the copay assistance cards for many of the manufacturers. And you could see the growth of copay accumulators over the 2-year period between 2019 and 2020. And it's gone up, I'm sure, considerably since then. But you could see the different types of disease groups that are impacted by them: cardiology, inflammatory disease, oncology, infectious diseases, which I focus on, and then endocrinology. But you can see how, look at infectious diseases up to, this is just their patients, are over 10% in 2020 were impacted by copay accumulator programs. Next slide. So the impact of these, and Charlie did a good job of walking through the patient scenario that the AIDS Institute developed. And so what happens is that the patient is picking up their drug throughout the year. They think that their copay assistance was counting. Then all of a sudden they go and pick up their drug, maybe in month, March or June or whatever, and they're stuck with this copay surprise. All of a sudden, to pick up their drug, they have to pay a whole lot of money, and that one they didn't expect at all. And two, it's a lot of money. And this is looking at 3 different products, 3 different drugs, product A, B, and C. And this is measuring the level of that copay surprise that the patient was not counting on, that they now have to pick up the copay assistance if they're going to pick up their drug. And you could look at the abandonment that happens, that people are just discontinuing their medication when it reaches, like, say, the copay surprise is between $100 and $200. For product B, it was like 25% of the patients won't even pick up their medication. And when that, copay surprise gets over $1,500, it's for the different products, it's between 25% and 36% of the patients will discontinue their therapy. Well, that's not good for, the patient. They're not getting the drug that their provider prescribed for them for a reason, because they have a health condition, and they could get sick, and it will add, it may add more costs to the healthcare system in the long run. Next slide. So I was looking over some of the notice of benefit and payment parameters comments that came in recently, and I saw one of the HIV companies had some really good data in there, and on the impact of copay accumulators. And this is looking at HIV patients, but first of all, they determined that patients with copay accumulator programs discontinue their medications much more often than those without. And they based it all on looking at their claims data. IQVIA did it. And I think it was more than just their company, it was all HIV drugs. So that was their first, finding. And then secondly, that people with HIV discontinue their drugs more than 2.5 times more as often if they're subject to an accumulator. And, this is bad. And, people who are on HIV drugs, they need that medication to stay healthy and alive, just like so many other diseases and illnesses. But for HIV, it's an infectious disease. And if you are not on your medications, you can transmit the virus to other people. So this is a public health issue as well. They also found that cost-sharing assistance reduces patient abandonment 90% across their hepatitis and HIV drugs, and that people with cost-sharing assistance are 5 to 19% more adherent than those not using assistance. So you can see, one, we all know the role of, Charlie talked about that, the role of patient assistance, but copay accumulators just are making it harder for that copay assistance to count and for people to pick up their medications, which will lead to abandonment of their medications. Next slide. So what can be done to solve this issue? Well, every year, the federal government puts out what they call the Notice of Benefit and Payment Parameters Rule. And this started under the Affordable Care Act. It's put out and it really guides how all the plans must operate in the years ahead. So they can easily say, the federal government, that copay assistance has to count. And that's what we've been doing in the patient community, is into encouraging this to happen. So in 2019, as we were working on the 2020 Notice of Benefit and Payment Parameters Rule, they always work, in advance for the future years. The Trump administration actually said, at our urging and request, that copay assistance must count in most situations, but it could be limited for brand name drugs that have a generic equivalent. And so that was amazingly good news for the patient community, with something that we've been working on for a couple of years, and raising this issue and telling them how this impacts patients. Well, that victory was not long last because they suspended that provision of the rule in August of 2019, citing this IRS HSA issue that Ashira just talked about. If there is a valid reason, and Ashira gave many reasons why there isn't a valid reason, there is, ways to get around it and to limit it. It doesn't have to stop all copay assistance. Not everyone has health savings accounts, and health savings accounts only, their deductible only goes up to a certain limit. So we were really disappointed with this, decision. And then to make matters worse, the following year, they came out and said that plans can implement copay accumulators. But they said that states, they would defer to the states. And so I'm going to talk more about that as we have worked in the states and at that point, actually, a couple have already had state legislation that says that copay assistance must count. And that's why we were able to get that provision in there. So in 2022, we worked really, really hard, the patient community and others, to say, copay assistance must count. And unfortunately, there was absolutely no mention of the issue at all. This was in the Trump years, the final months of the Trump years. But it was never finalized and in total. And by the time the Biden administration came in, they got to look at it again. And remember, they were trying to undo some of the things that the Trump administration had proposed. And we said, this is a great opportunity for the Biden administration to prove and to show that they do want to help patients and afford their medications, like President Biden, has repeatedly said. And so we worked really hard to try to get that changed so that they would mention the issue. And unfortunately, in the final rule, again, absolutely no mention. So we had another try in the proposed rule for 2023. And we had meetings, a lot of groups did, with the White House, the Secretary's office, with the new head of, the CISIO, which is the organization under CMS that governs private insurance plans, and to encourage them to say in the Notice of Benefit and Payment Parameters rule that copay assistance must count. Unfortunately, the proposed rule came out at the very last couple days of 2021, and there was absolutely no mention of copay assistance and accumulators, and much to our disappointment. So the rule was open for a 30-day comment period. A number of groups submitted comments. I'll go into that a little more. But it looks like, in the final rule, it's very difficult to get something in that was not even mentioned in the proposed rule. We're going to have to wait until 2024. So all the work that we're doing now is really geared towards 2024 for the next Notice of Benefit and Payment Parameters rule. Next slide. So, as I mentioned, a number of states are enacting laws that say that copay assistance has to count. And this slide's from End Alliance, the sponsors of today's webinar. And but a lot of work has gone within the patient group and other partners to go to the state legislators and say, this is what's happening to our patients. This is what the insurers are doing and the PBMs are doing. And so if you want to, make sure people afford their medications, pass these laws. And we're really pleased, 12 states and Puerto Rico have now passed legislation that says, and next slide, please, that copay assistance counts. And this is the model language developed by Arthritis Foundation and others. But I'll tell you though that this is great, but it does not impact the ERISA plans, the employer plans. And that's why we need a federal solution as well. That's why the notice of benefit and payment parameters rule is so important, because it not only impacts the individual and small group market, but it also impacts the ERISA plans as well, because the Department of Labor and Treasury are involved in those rules as well, in addition to the Department of Health and Human Services. Next slide. And looking at this legislature session right now across the country, this map is from the Arthritis Foundation. Yeah, the mustard colored states are the ones that already have laws, but you can see all the states that have proposed legislation right now. I think it's around 15 additional states, and there could be more. And what is happening is, there's a patient group lead in each of these states, and little coalitions are formed amongst the patient community and other partners to work on these, to present legislation, the hearings, work with, offer public comments, work on social media, conduct do opinion pieces. But a lot of work is going on throughout the country, as you can see, to raise this issue. Now, we're not going to be successful in all these states. Some of them have already, the point has already happened in their session, but some are, just beginning, and some are moving through the process like right now, like in Maine. Washington State, I know, had a hearing. DC has a hearing coming up in a couple of weeks. So, I'm going to go through and how people could get involved, but there's great opportunity at the state level to work on these issues. Next slide. As I mentioned, that we need a federal solution, a national solution. State laws are great, but it doesn't impact everyone. We could also go through the notice of benefit and payment parameters rule, but you can see we have not been successful yet. But there's also another avenue, and that's through Congress. And there's a bill that's been introduced bipartisan by Congressman Don McEachin. He's a Democrat from Virginia, and Rodney Davis. He's a Republican from Illinois. And what it does is say exactly what we want, that copay assistance counts towards a patient's out-of-pocket cost and deductible. It also closes the essential health benefit issue that Ashira talked about as well. So there's the bill number. It's only been introduced in the House so far. It's HR 5801, and it only has 17 co-sponsors. So we need a lot more co-sponsors, and that's something all patient groups should be, pitch in and contact their members of Congress, encourage them, reach out to Congressman McEachin's office and Congressman Davis's office, and ask your member of Congress to be a co-sponsor of this important legislation. Next slide. To get involved, a lot of the advocacy work has been carried out by the All Copays Count Coalition. And you can see they have a steering committee, the AIDS Institute, Arthritis Foundation, Cancer Support Community, National Hemophilia, and National MS Society. There's around 60 groups that are involved, patient groups, and they've been organizing a lot of the patient community outreach. There's a link here on how you could join the organization. Next slide. And they also put together a very strong comment letter from the patient community, signed by over 125 organizations, to the Secretary of Health, encouraging them to exactly what we want them to do, to make all copays count. And so hopefully this is, as I said, we probably won't be successful this year. It's very hard to introduce a new issue between a proposed rule and a final rule. But, at least it will show the administration that there is widespread community support and interest on this issue. Next slide. And I put together a coalition letter as well with the note on the notice of benefit and payment parameters rule with the Autoimmune Association. We had over 50 groups sign on. We touched on a number of cost sharing issues, but we obviously included the importance of making sure copay assistance counts as well. Next slide. So if you want to get involved with the All Copays Count Coalition, I had earlier the link to the main coalition, but there's two different subcommittees that people may want to get involved in. And there's a federal one, and Rachel Klein of the AIDS Institute and Kim Calder of the National MS Society are the two leads there. And I would encourage you to contact them to be involved. They have listservs, and they also have periodic calls. And then next slide, if you want to get involved at the state level, the two leads there are Stephen Schultz with the Arthritis Foundation and Jamie Saxton with the Immune Deficiency Foundation. And both their email addresses are there. And then also I have a link here to the model language for state legislation. But and you can get involved in both the state and the federal. There's a lot of work to be done. And I think, through all these efforts, that through all the different groups working on this, we are, raising the issue to the policymakers, but we have more, obviously, we have more work to do. So thank you very much. And I'll be looking forward to any questions that you might have.
Great. Could you advance to the next slide, please? Thanks so much, Carl. The last thing that we just wanted to flag for everyone before we open it up to questions, if you do have questions, feel free to start putting them in the Q&A. We're going to be addressing those next. But what I wanted to show everyone is this Copay 101 hub that AIMED Alliance has launched on our website under the Initiatives tab. It's a Copay 101 hub. And so this has an explanation of all the different copay accumulator programs that we've talked about today. So the standard copay accumulator program, the maximizer, the non-essential health benefit issue, and an explanation of the IRS HSA issue. We created this resource because we knew we threw a lot at you today. It's a lot of information, a lot of stuff to take in. So we wanted to provide a platform that you could return to after talking internally with your organization, and a helpful resource to help just all of us work together and be better informed in our advocacy. Next slide, please. And so if you're looking to take action today, we encourage you to visit the AIMED Alliance Copay Hub 101 Hub on our website and share that resource with folks that you think might be interested. We also want to encourage everyone to download and share our AIMED Alliance IRS HSA fact sheet, which goes through the analysis that I gave today. And lastly, we want to encourage everyone, in addition to getting involved in both the federal and state levels, to sign up for our AIMED Alliance newsletter to stay informed on updates with Copay Accumulator reform. In our newsletter, we provide updates on which states have introduced a Copay Accumulator legislation and also states that have adopted Copay Accumulator legislation. So I'll be dropping a link into the chat that will allow you to register for our newsletter. And I also see that we have some questions that I'm going to pose to our Charlie and Carl. So Charlie, I think this one is for you. Is there a way to know if the prescription plans have the accumulators on them before signing up? Would I be able to see if my plan currently has an accumulator on them?
Yeah, thanks, Ashira. So the answer to that question is they should. It should always be in the contract. The patient should be able to know that there's an accumulator program in there. The issue that we run into, as many of us know, is that these insurance plans are very, very complicated, have a lot of provisions and a lot of clauses in the contract. And so a lot of times, although yes, it may be in the contract itself, it is very difficult and very tough for us to expect patients to be able to go through, find the accumulator clause, find where it's going to be, and then know exactly what a copay accumulator is. Because on the other side of that, many times patients aren't aware of what copay accumulators are. They're not sure exactly what that's going to mean for themselves and what it's going to mean when they get to the pharmacy counter and find out that none of the payments that they've made from the copay assistance has actually counted towards their deductible or their out-of-pocket maximum. And Carl, please fill in where I may have left blanks there.
Yeah, no, Charlie, you're exactly right, everything that you said. And this has been, I think, one of the travesties of this issue, because, one, the insurers are getting more money through this and and secondly, people don't even know about it. And that's why they have this copay surprise. And as Charlie said, this language is buried in the contract. Well, who reads a plan contract that's over 140 pages long? And they use language that's difficult to for you to understand or to figure out. We've been encouraging CIO in regulators to say that this needs to be in the summary. Well, one, I don't want the copay accumulators, but if they are doing it, it needs to be in the summary of benefits, document, which is that 6 or 7 page document that people have. I've only seen one plan, national plan, do this, and I think it's important. I have seen a little more transparency this past year. And putting it up front a little more in some of the documents, but it really needs to be in that summary of benefits page, because people really need to know if they're going to be subject to this or not.
Thanks, Carl and Charlie. Another question that I know is frequently asked is, although we're looking for state action, what is your opinion on kind of the responsiveness of legislators once they hear about this issue? Carl, do you want to start?
Yeah, I think a lot of people are very sympathetic, right? Everyone's talking about the high cost of drug prices these days, right? It's one of the most, talked about issues. But, what I say is what really matters, what people are really talking about is how much they're paying for their drugs. And people are saying, oh my God, I'm paying $1,000. I'm paying $1,000, $2,000 for this drug. And, so, the patient assistance is really helping. And when this is actually adding people's cost, I think state legislators are very sympathetic to hearing the concerns of their constituents and why they can't access and afford their prescription drugs. Also, they need to hear, there's always two sides to every story. I think it's important to hear both sides. But I think the patient community is definitely right on this one. And, some of the arguments from the insurers are this messes up insurance benefit design. And I keep on saying, what, they don't want patients to get the drugs that their providers prescribe? I just don't understand. It's not messing up, any insurance benefit design. But I think they're sympathetic voices.
Charlie, did you want to add anything?
Yeah, I just wanted to mention, just about the state versus federal component of this is, I also think that they play well off of each other in the sense that, at the federal level, we have 12 states that have passed copay accumulator language plus Puerto Rico. And so there's momentum at the states. And so not only does that help with more states introducing legislation like Carl showed on the map, we have 15 states that have introduced legislation so far this year, but it also shows momentum to the federal delegation. So, you can either go to a state delegation that has already passed it and say, your state has taken this initiative, we would like it if you would sign on and co-sponsor this piece of legislation, or, go to a delegation that hasn't passed it and say, you can lead the charge instead of the state leading the charge. And so I think it's very important that there is both kind of state and federal action in play here so that you can not only cover the most ground, but also the most lives, considering federal plans will cover different lives than state plans will.
Great, thank you both. And I think we probably have time for one more question, and I think it's being raised in the Q&A chat. And so really, how do you explain to employers why these programs are bad for their employees and bad for patients, and really the repercussions of patients not being able to access their medications? Charlie, did you want to start on this one?
Yeah, I can start on this real quick. And so, when you're talking to employers, a lot of the times they say, why is this my issue, or why should it be an issue to me if the employees are the ones having issues getting their medication and it doesn't cost me more? Well, the first thing I'd respond is it actually is costing the employer more. Not only does it tangibly cost them more due to the fact that the patient could have to go to the emergency room, they could have to see other doctors, and there could be more cost to them health plan wise. There's also the intangible issues that you run into, the lost work days that the employee is going to have, the less money that he's going to make for the employer. And so, there's both issues kind of tangentially, but also directly when it comes to the cost to the employer. And, obviously the patient is not only going to have his health affected, but also their work. They're going to have to miss days of work. They're going to have to catch up, and that's also going to indirectly affect the company or the employer. And Carl, I'll kick it to you to any blanks.
Yeah, I mean, I agree with everything that you said. I think isn't the whole idea is to make insurance work for their employees. And that if I was an employer, that's what I would want. And this is actually, a breakdown of our insurance system. The drug is covered, but the patient can't afford it, because of the insurance benefit design. And, I think a lot of employers don't even know this is happening to their, the PBMs come to them who run their plans and they say, this is a way for you to save some money. And actually, the PBMs are actually making a lot of money from these. And I don't know if they're passing that on to the employer. So the employer may be concerned about these. But as Charlie said, there's the long-term cost, so maybe it may save a little money. I don't know for the employer this year, but what about the long-term health of your employees? And so I would just use those arguments as well.
Great. Thank you both. I don't see any more questions in our Q&A. So with that, I think I will close us off for today's webinar. I want to thank everyone again so much for joining. Thank you, Charlie and Carl, for providing some really great and important insights on copay accumulators and why these are really harmful programs for patients and what we can do to reform them. This webinar will be posted on AIM Alliance's website. Just give it a couple of days. It'll be on the Copay 101 Hub. Thank you so much, everyone, for your time. Have a good rest of your day.
Thanks.
Thank you.